Right. So I've introduced Stephen and Reza. I'm the medical director in family medicine. Been practicing a long time. Stephen and I met when he was in medical school and I was training at the same hospital in Brooklyn. And we talked about medical records, and he told me his vision, which has now come to fruition. And I've been working with him during this time. And Razor has created the IT of this record that you see here. So I'll do present now, and I'm going to go ahead and show my screen. I'm going to get rid of this. And I'm going to pull up the browser and get into Universal Medical Record. So you can see, well, here we go. All right, so I'll go over here and type in universalmedicalrecord.com, do the portal. So now, so now I'm going to log in. And I'm doing it from the beginning. So you're going to see the whole process. A lot of this will be cut short when you have a connection to the record and you're registered with it. All right. So now let me go to home. I'm going to look up a patient record. So here's my information. It knows this is me. I'm registered. It gives you my information and my relationship to the record and communication to get in touch with me. And everyone has to be registered to use the record. So they have to be vetted and registered so we know who they are, obviously for HIPAA reasons. So we'll get into that in a little more detail. So we're going to pick up a patient that I had created to demonstrate this patient's history through medical delivery and the different records that she generated during this time. So we're going to show the details and it's going to demonstrate. So we'll have a picture of the patient, all of their demographics, all their information here. We have a SOAP notes that we'll get into later. And then we have the different types of codes here that we can deselect just to look at the types of codes that we may be interested in this record. Because if you were to think of a patient that has this record from birth to death and has traveled across the country and seen many different providers of all types and been to different facilities for testing, et cetera, and during their life went into physical therapy, rehab, nursing homes, in and out of hospitals, et cetera, and all these EMR systems are connected to UMR, then all this would be providing data into this one record. Now, rather than having what we normally have today, when people are looking at medical records, if you're going to get copies or faxes or whatever, it's going to be a lot of paper that's going to be stacked on top of each other. And then you have to go through different records from different locations and getting them in the right order chronologically. This does all this integrated into the different disciplines, which we'll get into. So you can deselect any information you're not interested in, because you can imagine having hundreds of thousands of codes in this record of a person over lifetime. So we have table of contents. So this is the table of contents of the book of their medical records. And then we'll get into remarkable disciplines down here, and I'll explain all this later. So the first thing we'll look at is the master patient code indexes. And this is all of the codes that have ever been generated over this patient's history. We can, again, deselect information we're not interested in. We can also look at particular codes that we want to select out of this record over the past 10, 20, 30, 40 years, whatever. We can do matching or partial matching of the code by name, by words. We can look at dates to pick out of this record and any other information that we may want to provide, particular provider IDs, the names, a facility ID, different locations, and their names. So all this can be entered and select out of that to make it a lot faster to look for very specific information that you may want to know. Has this patient had a previous back injury? What facilities have they been seen? What are the providers that have provided care of this person? So to look at all these master patient code indexes here, and there would be tons of them. I'll go down to 20 per page just to make it. And then we'll go in and look at, first of all, anytime you hover, you're going to get all the information, the disciplines, gives you a description of the code, the dates, the time, all this for all of these codes. So you get a synopsis of the information of each of these codes. So if we go down to the bottom, I'm just going to go through and just show you the pages and pages and pages as this changes over time. And it just goes on and on and on. And you can imagine, and this has changed color because of the dates that I'll go over in a minute, that shows the particular times that those codes were generated as we go through this record. You can see it just goes on and on. You can imagine someone having hundreds of thousands or even more codes over a period of a lifetime, for example. Or if you just wanted it the past year or so, you could select that. And that's what's done here. We have the ability to select the different aliquots of time, the different amounts of time for each color, and then this will all change colors as you change the dates in between. If you want to see what's the codes that were generated in the past 3 months, from 3 to 6 months, 6 months to a year, and then anything older than a year would be blue, for example, meaning the oldest color would be the end of that. So that's something we can do for all of these records, and I'll show you that. So this is looking at all the master patient code indexes. Now, for HIPAA reasons, we have last record accessed. That's going to be who is number one registered. Over here, we can look at all this information. We can pick whether it's the name, a facility, the dates, or any other types of information, SOAP notes or the record review. We'll get into SOAP notes later. So last record access. Currently, we're in use. It's me that's accessed it because I'm registered. This is my facility name. You have all the different people, and I'll increase this to 20 and go down and show all the different, over time, the records that have been accessed. So if someone has access to this record and they have the ability to access because they're registered, but maybe they didn't have the need to look at that person's record, it would be documented here, the date, what they looked at, the amount of time they spent, who they were, and their relationship. And here you can get the demographics of that particular person. Whenever you do that, all the records that myself here has generated in this record. So there's different ways of getting access to data. Then unremarkable disciplines. When you're asking questions, have they ever had this problem or that problem? If you look at unremarkable disciplines, this tells us that there is no information in these particular disciplines. So you really don't need to ask specifically in this record if this information is here, because once it's remarkable, once there's information entered in one of these disciplines, it's going to show up in the remarkable disciplines, which are listed here below, and we'll get into that. Legend just gives you an explanation of all the definitions of things, what a code is, the types, version, dates, frequency, how many times a code is there, strength of a prescription, the route it's given, how it's given, not available, and then the 4 colors that we use to segregate the data based on time units that we can change looking at data. Important as healthcare providers. This is where everyone has to register. We know who they are, how to get in touch with them, their ID, their names, what type of medicine they have, MD or DO. Remember, these are the people that can generate codes. And if they now allow nurse practitioners to generate codes, or physician assistants, now called physician associates, they could be registered here. The last date that they had data entry, the first date, and the frequency of how many times. And with this, we can go to frequency, and we can very quickly jump and look into all of the codes that they have generated. Those 15 codes would be right here, and medications and diagnosis codes. And when we go over that, we highlight the information as to the disciplines and other information regarding all of these different codes, and then the location, and we can drill down to that facility location, for example. So that's quickly providers. Go back. Now we have ancillary healthcare providers. These are non-prescribers, but they may be nurses. It gives us how to contact them, their names, their degree, they may be physical therapists putting information in there, but they can't generate codes. Maybe nurses, it may be other ancillary healthcare providers. Any IDs that we have to document them, phone numbers, emails, etc., fax numbers, whatever, to contact. So anyone that puts information is registered, and we can contact them for more information. Next would be ancillary network contacts. This is very interesting. These are people that are family members and friends. These are people that a patient would allow to have access to their records and how to contact them, their names, their relationships, anything regarding their profession, phone numbers, emails, fax numbers, etc. Because sometimes certain patients want family or friends to have access to their records for whatever reason. It could be a lawyer, could be an accountant, could be many different people, but they have the right to allow people to see their records. Obviously, we want to protect them with HIPAA. So this would be a registered person that would have access. Disclaimer is just regarding the record being completed and accurate based on the information that's put into the record as a disclaimer. Advanced medical directives is extremely important. And there's 4 types we have here, the MOLST. And here's an example. We'll show this one. It has changed over the time. The patient's MOLST report has changed. And here is their advanced directives here. And it's a form that has been scanned in, and the patient can change it at will. And it just keeps up the latest, because that's what is going to be active, is the latest one. Over time, they may want certain things and not want things, may change their mind for whatever reasons. It's their right. And we would have that centralized record in this. No matter who's accessing the record could see what their wishes are. It's especially important in emergency room care that, if they're in the emergency room unconscious, you know what their wishes are. you certainly don't want to do something that is against their will. So we'll clear this. We'll just go back, clear this, and let's see. Razor, how would I go back from here? Oh, here it is. I'm sorry. I'm used to the button over here. So
I was too slow clicking the unmute button.
Right. I'm slow in finding back button. So next is living will, and here's the date, first and last dates that this has been put in. And we can look at their living will, and there's one here to show, and I can show the living will, and here it is. And as their living wills may change, that's fine. We'll just put them in here, and it'll be the latest living will. Organ donation wishes. Of course, you don't see it until you want to show it. So privileged information. So healthcare proxy, organ donations, what organs they want to donate, and all the legal aspects of witnesses, etc. And then the documentation of these oral directives, and we can show them. And here's the ones that we can put in here, completed. Which ones are completed, and as they change over time. So that's advanced medical directives. That's so critical for a patient's wishes. Emergency information, these are contacts, how to contact them, last name, first name, relationship, phone numbers, emails, how a person wants to be emergency contact. So this record, when something occurs that the patient's wishes is to have certain people contacted, and you can imagine having 20 people, 30 people, 40 people contacted for an emergency or whatever situation, this would do a blast to those people at one time instead of looking up, calling, trying to contact everybody one at a time. This would just do it all at once. Okay, so we'll get out of that and just back out of it. Then we have healthcare facilities. Healthcare facilities are all the facilities that have provided care and have a record in this for the patient to be, and we can review all of these. We can review all of these. It's thinking. Looks like my browser is slowed down here. Yeah, it failed for some reason. Try it again. Having an IT moment here. Let me try emergency information again. Let's see. There it is. So, okay, go back. There it is. It's finally popped up. Healthcare facilities. So these are all of the healthcare facilities. They have an ID because they're registered. We have a facility name. It may be an office. It could be a hospital. It could be a rehab center. It could be, let's go to page 2. You can imagine having 50 pages, 100 pages of this. It could be a nursing home. So here's a friend of mine, Ralph Pudapanda. His real name is Babendra, but so, and medical records. So there's all types of facilities that may have information here. And we can look at the last date, the first date, and we can highlight that frequency and drill right down to that particular entry into the record right here. There's the diagnosis that was put in, and there was the provider that made that diagnosis in here. And we can drill down and look at the demographics if we wanted of that provider right here. If we wanted to physically contact them. They're registered in the record, so we have all that information here at our fingertips. Next is patient schedule, and this would be a schedule of what the patient's availability is, and they would put in here when they are able to do visits, so people could go in here and say, okay, the patient's put in here populated this record, and they let us know that they're available Tuesdays, Thursdays, and Fridays, different hours, different days, so that we know when to make appointments for them, so that we won't have a conflict when we're trying to get appointments for them. The patient could actually put this in here, and each person that's seeing the patient could then fill this out and give them an appointment so that they aren't getting double booked on the same day or making it impossible for patients to be able to be adherent to going to the different records of their visits. Patient demographics is exactly that. This is all the demographics of the patient, all the information that we have on them. Insurance information, and that changes over time. So it keeps a history of that. And SOAP chronology is SOAP notes, and I'll talk about that in just a minute. But these are the SOAP notes, and these are, SOAP stands for subjective, objective, which is physical exam findings, vital signs, assessment, the diagnosis codes, and treatment, the things that were rendered to the patient, whether it be medications, could be testing, those sorts of things. And it gives us the times of these different SOAP notes. And these SOAP notes are communications between different providers. It may be a nurse to a doctor to doctor, that sort of thing. It's a communication inside the record where they have access to see all the diagnostic codes, all the results of the labs and medications that we're going to get into. And now we're going to go back all the way to the beginning of the record here. I want to back out. And again, it's easy in and easy out to go in. So you can't get lost in the record. You just go back out. So it makes it very quick and easy for people to learn the record. So now we get into remarkable disciplines. And these can be segregated by date intervals, and that will change the different colors here. Again, we can go over here and we can untick a type of code, so they'll disappear and these may go away depending on the types of information in these codes if we're just looking for specific information. So if you can imagine having hundreds of thousands of codes in here over time of the person's medical history as they change providers, locations, records, and you're looking for just a specific type of information. You know, do we have a code of this patient's back injury 30 years ago? Have they ever had a previous back injury? As opposed to a claim that this is something new, for example. Do we have an old x-ray? You can just segregate that information here. And then you can change it with color code. So you can look at what you feel is the most relevant to your particular discipline. A cardiologist would have a different perspective, or other specialists, compared to primary care, for example. They may want to see different intervals of time that they would look at. So that allows us to segregate data here. Now, if we look at what's in these disciplines, look at the codes, we'll go to one that's kind of the central part of this, radiology. And I'll show you how these codes are all interrelated. So we populated it, and I designed this to show how this particular person, because they didn't have a UMR type record, they actually, unfortunately, got something that's very common to people that can happen. Here we have a code, the type, the date, the version of that code. And when we hover, we see that this myelography test is a neurology test and also orthopedic test, because these disciplines are related. And sometimes orthopedists may order a test that neurologists may also order back and forth. So this is important to let us know that this one code is not just radiology, but it's also related to neurology and orthopedics. So an orthopedist may be interested in this code, or a neurologist. So we have the date it was first done, the last date, and the frequency. Unfortunately, between January the 15th and February the 5th, this person had a highly technical, hopefully once in a lifetime test 3 times. And we can drill down from here and we can see the 3 service dates of this test, the 3 different providers that did the test, and where it was done. So 2 things are shown here. One is Ned Strupp, the second person that ordered the same test on this patient, didn't know that it had just been done a few weeks earlier. And then Phil Triss came along and did the test a few weeks later, didn't know that Ned Strupp had also done the same test. And unfortunately, the same test had been done in the same facility between the first physician and the third physician, when in reality, this is probably a test done once in a lifetime. My God, you don't want to go through it twice. You certainly don't want to pay for it. An insurance company probably won't pay for it. So we can, if we want here, drill down on Oscar Stocks, and we get all of his demographics. We get all of the tests that he's ever put into this record here. And we can, again, get information on each of these codes just by hovering, and tells us what disciplines are related, and it gives us a description of what they are. The first and last dates, times. Well, this is just the dates and time, and where it was done. And we can drill down on the location, the facility name, and get provider details of that. It's a little slow. But this will also give us a provider detail of that facility, because the facility is a provider. So that's one example. Let me go back here to Nashville Imaging, and here's the facility here. So we can get in touch with that facility for whatever reason we may want. So unfortunately, this patient went through basically the same test 3 times because they didn't know it had just been done a few weeks later. For whatever reason, the patient didn't tell them, or didn't know it was a different, same test, whatever. And this is a waste of resources, unfortunately, and danger to the patient to do this test. So that's an example of just looking at that particular, and here's all the different radiology codes. And we can just hover over these and look at the disciplines it's related to and the description of the code itself. So for someone that wants to know what these codes are, they can just hover and get that information out. And we'll go back and we'll look at medications, prescription and medications here. And here we have all of the different medications listed, how many times they've been refilled, the different providers of those medications, and the particular facility where it was filled. It could be a hospital, it could be a doctor's office. They do prescription fills, it could be pharmacies. The last date and first date that it was filled, and how many times it's been filled, which is of the frequency of this particular provider. And then it goes on for pages and pages. Because of this, when you have a list of all of the providers, you have a list of their medications, their allergies that are put in by different providers that add up over time into the record, because you have the disease codes, the diagnostic codes, and you have laboratory data in here. You now can do not only a drug, and a drug allergy interaction, which most medical records can do, But if you have a comprehensive record like this, and you have laboratory data, you can now do a drug laboratory interaction. And because you have all the diagnostic codes in here, you can now do a drug disease interaction. So if a person has a certain disease, you may not want to prescribe a certain medication. An example would be for a person that has gout. You probably would not want to give them a diuretic because that could exacerbate their gout. And you would get a drug disease interaction because a different provider somewhere put that code in here, and it would be in the background doing a drug disease interaction, just like it would do a drug laboratory interaction. So that's all the basic information we have in all of these codes. But when you look at one particular code, as you've seen in the record, when you hover, you see that things are not just sometimes one particular discipline, but that X-ray, for example, here, chest X-ray, yes, it's radiology code, but who else might be interested in looking at that information? Well, the different disciplines that could be interested in generating that code or have information in a chest X-ray that may be relevant to their particular discipline. For example, here, orthopedics, pulmonary medicine, and rheumatology, because those are the different disciplines that can see information located in a chest X-ray. So all these codes are interrelated by discipline. So rather than segregating data for each specialty, here we've actually shown how a code, any code, can be related to different disciplines. And we'll see that as is appropriate here for each one of these codes that you see in here. Sometimes they're just one, sometimes they can be many codes. It just depends on the code itself and what disciplines may be interested in the data or themselves generating that particular code. So that's the basic overall record. Now, the other thing we have here are SOAP notes. And their SOAP notes is a way that providers in this record, nurses, doctors, specialists, can interact with each other rather than, for example, a scenario where a nurse is in a nursing home, for example, and they need to get in touch with the doctor regarding this patient with some information. They can, in this record, the patient's record, generate a SOAP note, subjective, objective, where they would have the patient has a certain complaint. Objectively, they may put in vital signs. They may have an assessment, what they think is wrong. They can't make a diagnosis code, but they can make an assessment code, respiratory difficulty. And the plan would be to contact the physician on call, the provider on call for that patient. They may not know who it is, but the record in here could have the record of the physicians and the other providers that are responsible on call for that patient, and going through and getting into the system in here where the providers be able to get in touch with them and send them a text message with that record that they could review. When they get into the record, they would also get into the UMR record. So they could, using all of this ability here of dates and the information that they want to look at the patient's record, and then make a decision clinically based on the most recent data that might be chest X-ray, EKGs, lab tests, medications, review that. Then they would take an assessment, a diagnosis, a presumptive diagnosis, a working diagnosis, and a plan of ordering any new medications, lab test, referrals to anyone, or send them to the emergency room. And that would trigger to send that to emergency information to the patient's relatives as per their request, for example. So that would allow them to do this back and forth. And physicians could send these SOAP notes back and forth to each other. And that's what SOAP is. It's a way to communicate. You could create a note, you have the management of the notes, incoming, outgoing SOAP notes, and the chronology of all these different notes that have been put into the record. And you can see, just like we looked at all the different codes, you could look at the different, let me put in the patient here. And you can look at all their SOAP notes that have been generated in the record. And we're going to show the SOAP chronology. And these are all, we could review now all the different communications between the different providers, nurses, doctors, with each other, and their subjective, objective assessment and treatments with that patient. And we just have pages and pages and pages. We've made just sort of examples of this for the record, but that would be the communication between people. So that's basically the overall record that I wanted to show, and wanted to ask if there's any questions that I could take at this time.
Hi, Dr. Mills.
Yes, hello.
So this is fantastic. I mean, it is in detail, and it will solve a lot of problems when it comes to patient care. But how is this captured? Are we mapping this through an EHR, or does this need to be captured manually and entered in onto the software?
Thank you for the question. That's a wonderful grassroots IT question for Razor.
I will ask that question first. Wayne, If you can go back over the genealogy for one
Razor,
second.
Stephen, let's let Razor ask the question, then we'll go over whatever. Let's go answer the question first.
Can
Then
you
we'll
repeat
start
the
with
question
old business, then new business. So Razor, could you answer his question, please?
Can you repeat the question, please?
Yes, Raja. So, how is this data captured? Do providers or practice need to enter this manually, or are we mapping it from the EHR?
Well, the intention is to be mapped from EHR using Stephen?
CCD.
Okay, let me take this over because this is the phase 2 entity. When Dr. Wells explained the different types of codes, okay, right now we're missing putting in the ICD-10 codes through a whole plethora of being able to sit down and map out genealogy. So what we were going to do initially with iPatient is to be able to just take the diagnosis and treatments that would eventually be related to a code under the ICD-10 codes, okay? So we're actually pulling that from the existing EMR information. We're using iPatient, okay? Now, the fact is that we could technically take a diagnosis and map it to an existing ICD-10 code, but it's not going to be put into the exact genealogy of where it should lay. Now, with that stated, there is something that if you pick up all the coding systems, they do put them into a, let's say, a basic type of genealogy that you would find them under, not the type of genealogy that we have come to do, okay? You may find, for example, a chest x-ray would just fall under all radiology procedures, okay? But we took, for example, a chest x-ray and not just put it into radiology and maybe medical procedures, but we have taken that chest x-ray to relate it to the full genealogy of cardiovascular medicine, pulmonary medicine, orthopedics, rheumatology, and medical procedure and radiology.
Stephen, I went over that, but to answer his question, the way to answer it, I see it, and Razor, correct me if I'm wrong, it's going to be the CCD that all EMRs are required to be able to export and import. So that's the mechanism. And then with it'll be HLA 7 and other things that import the data from these different EMRs, from laboratories, from radiology places, facilities, etc., hospitals. All that is captured through the different mechanisms that Razor is designed to capture for this record.
Fantastic. Thank you so much.
They won't be physical. They won't be typing it into the record. No, that obviously is not going to work. That's not a system that's viable.
Okay, Dr. Wayne, I like to bring up one thing that when we worked with the previous company, FigMD, we worked for registries. Okay, a different kind of registries we worked with. Me and my colleague Mukund, we worked with otolaryngology, AOHNS registry, and they were participating for the MIPS program, CMS MIPS program. Okay, now this all registries have their members' data with them in a structured format, but not in this format. That will help the registry as well as for their members. So data is available with the registry as of now in a structured format, but not in the markable or a discipline. So I'm just showcasing one more opportunity wherein we can kickstart with one registry to showcase what we have, and they would be the right person to help us to move forward with the existing technology that we have for. And this is really helpful for their own research purpose as well.
Right, I agree. And the problem we get into, and you make the good point, that all these people are doing different things. And unfortunately, they're all silos. They don't interrelate and they don't share. But one thing that does share is the EMRs are required by the meaningful use definition to be able to import and export this data that I've shown you. They're required. But the problem becomes if you just were to use, for example, different records sharing information, you're going to get a chronological list of data, one record on top of another record. It's electronic paper, I call it. And you would have to scroll down over time looking at subjective, objective assessment plans of the EMR notes and all the information in the EMR notes that you mentally, you're going to have to start writing down kind of what you just asked. What were the different diagnoses in each of these visits? What were the different medications prescribed? What were the different referrals, and where were they, and when were they, and what were the results of the referrals when they saw them? And so you would be collating, organizing all that data, which is exactly what UMR is doing automatically as the EMR exports the visit into UMR and integrates it already into the record that's already set up here, as you see, in the disciplines or the medications or the laboratory testing or the radiology section, so that it builds on it and you have a way of getting the data. The problem with the medical records today, besides them all having a different view, a different amount of information, and a different feel, and they're all unique, unfortunately, the only common denominator is the CCD that can import and export those 17 or so pieces of information, like the demographics and the diagnosis and the medications. So we aggregate that and we put it into disciplines that, as Stephen was mentioning, are interrelated. It's not just it's a radiology code, but it's a code and related to all the different types of medicine that would use the code, besides being a radiology and medical procedure code. So it, instead of segregating data and putting them into a discipline by a specialist of siloing, it makes them look at all the other information that would be interrelated to their data that would help them to look at the information for them to be able to make better informed medical decisions based on comprehensive, integrated information.
Yep. And do we also consider the the SOMAT codes?
Yes, Stephen?
We actually looked at the SNOMED codes, and once we there is actually a crosswalk from the SNOMED to ICD codes, but once we can get working and we get the cash flow to start supporting Peter's company to start doing this, then we could actually manually also do the SNOMED codes, which would then integrate this thing into an AI program. So yearly and going forward, if we had any other changes, it would automatically be, with artificial intelligence, we'd actually be able to predict the valuation of the genealogy, which has already been done in terms of the AI intelligence. Is built into the Medcodepedia, which I don't know if you want to go into the Medcodepedia, Wayne, unless this whole meeting is fully digested, but we can show you the trade secrets of this company.
No, Stephen, I don't think that's important right now. We're trying to keep this high level, and he needs to I'm trying to have him appreciate the depth and scope of this record when you have comprehensively all the codes generated from birth to death. Imagine the research that's available here, but just trying to, more importantly, for most people as a provider daily, trying to do the best job in the shortest amount of time, getting into this record in 3 to 5 minutes, finding that information you're looking for and getting out and taking care of the patient sitting in front of you. This is what this record allows you to do, as opposed to looking through, many, this record, as you can imagine, in a chronological order that's doing a SOAP note over and over and over and over, and you've got no way to integrate the information into this one record.
Mm-hmm. So what I'm saying is the only way that we can facilitate this service through the EHR. Is there any other way that we can give this to the patient and they would start maintaining their records?
Well, let me just say one thing, okay? We, through Peter's company, could take old data and use information, but you're talking about garbage in and garbage out. One of the first features, if that Wayne described, was the master patient index. Using iPatient, and just by getting the different information, we would actually be able to show a master patient index. If Wayne wants to go back to the master patient index for one moment. This would be the initial phase of what the patient would see, was a chronological order of their data, okay?
Mm-hmm.
Which this gives the patient the understanding that we have all their information. This would then, in phase 2, without any changes to any patients working, you would then see the complete full-blown picture of what Wayne broke down in terms of the genealogy, okay?
Got it.
Which, and by the way, even with this information here in the master patient code indexes, you would be able to see in terms of time management what's going on with this patient. It's just going to take you a longer period of time to figure things out. And you could also, I believe, still filter by doctors and stuff like that. But until we have the next phase of this, and that's why I was hoping that we would have had 1,500 providers on board already. This will accelerate the next phase of this development. And it's not development. It's just putting in, listen, it's going to take 30 or 40 people 9 months to get all the billing codes tweaked, okay? Because we stopped doing the billing codes in 2012 when ICD-10 codes came out, which is nearly now 12 years ago. And we weren't going to do 180,000 codes, which would take 5-6 years to do, for us to do it. You know what I'm saying? So we have to build this thing in stages, but the patient is not going to see any difference. They're just going to see more additional services for the same situation.
Here's an example. I just went through 20 pages of 20 items per page. And this is a record that I made up, a simple record, the simplest I could make with a minimal amount of data just to kind of demonstrate the record. And I've got 400 entries in here for a very simple thing. As you can imagine over time, the amount of records that would be here and how anyone would ever try to navigate the data looking at electronic paper of each visit. and then try to integrate the different information and then locate the information and get the results of what it is. It would be a Herculean contest to be able to do it. So that's where this really allows you, when the patient is sitting there, rather than asking those questions, where did you go? Who did you see? Where are they located? What did they do? What did they diagnose? What medications did you give? What tests did they give? Who did they refer you to? Have you gone? What did they say? And going through this whole, historical perspective of their visits since you've last seen them, trying to keep up with what's going on with the patient, you could simply get in a UMR record and see all that data and say, I see you saw this person. They said this, they ordered this, they did that. And you've got the whole record in front of you, and you can get in it, get your information you need, whatever it is. You can segregate it the way you want to see it, and uncheck a lot of the stuff that you're not interested in, and then get out of the record and then take care of the patient, because you now have the most up-to-date information to make the best decisions and to order the appropriate lab test based on what's been done already, and not repeat things as I've shown an example here, not give the same medicines because they never bring their medicines and they don't know what they're taking. You're not going to give them a drug allergy, drug lab, and drug disease interactions because you have all that record here when you put medications in, et cetera.
So I'm just thinking other way around, okay? The route that we have selected is through the billing codes to get the.
Well, no, not at all. What happens when the diagnoses and treatments are sent now to iPatient? Once we have our billing code generator, we will be able to basically provide a code for those diagnoses. Okay, not that they're going to be reimbursable codes, but we're going to maybe even mask the codes or even use these codes. So this way you can see progression of disease management using the American methodology. Okay, so we may be using this stuff, but eventually maybe the Indian government will want to use these codes to support the complete mission here, which would be wonderful. Because one of the things that I'm trying to do is standardize the codes, even though the world uses the ICD-10 codes without the clinical modifier. But this may be a value that we can basically foster and promote the stuff with the AMA, which basically makes the CPT codes. And somehow the government uses clinical modifiers. So this may be a way of standardizing languages without anybody having to really do anything. In addition, one thing is that using our coding system, we can translate this thing into maybe the 7 major languages that are offered.
Okay. No, I got your point, Dr. Cohn. I'm just thinking other way around. Okay, if I'm a citizen of US from last 30 years, I have a medical records with different providers, and I have a patient portals with different EHR companies. When I got introduced with this kind of UMR portal, as a patient, I would like to maintain my records myself. Is there any API that I can get to my patient portal and you extract the data and mark them as a discipline?
Good question, and the answer would be we would have to build an API to be able to put that data in. However, any data that would be used would have an asterisk next to it because it was not collected directly from the doctor's office, unless it can be proven as such. Because now we're going to be going forward with information now that you may change your doctor's thought processes from the past. So now when he goes sees the patient, he may now make a more definitive diagnosis and treatment based on past information that he may never have had, and those will become unstarred.
Okay.
Right. And the thing is, you're right. This is the patient's record. They own the record. It's their record. They paid for this record. We want them to have access to it, and they have access to this. Number 2, we want them to share it with whoever they want. That's their business if that's what they want to do. I mean, I don't know that it's really recommended, to go doing that, but they have the ability and the right to do it through this record by putting them, listing them in here as the ancillary network contacts that we showed. And also to be informed who they want. Should anything occur, should they be sent from the nursing home to the emergency room, certain people could automatically be notified without spending precious time working on notifying people when you should be taking care of the patient on an emergency basis, being sent to the emergency room, et cetera. So that's where this record comes into play to keep people up to date, and the patient being able to look at their own record and the summary of it. They can look at the EMR records as they're all generated, I suppose, but this is sort of the summation of all those visits in one place that they can review at their leisure. And they can, as you say, check it for accuracy, and eventually, I guess, they could add anything they want. However, you'd have to worry about psychological issues with patients, and that's why Stephen said there would be an asterisk that's a patient entry and not, a professional entry and a diagnostic code that would be put in that entry.
I take that back, by the way, and because when you look at the record, an asterisk means the latest change that just took place. It's not giving an asterisk much, but there may be a question mark next to it.
Yeah,
questionable data. So
it's a different legend. Yeah, it's a different legend than this one here. I mean, you just add to your legend if you're going to let patients do that. If that's their right to do it in their own record. But you just change whatever, put patient entry, just mark it patient entry. This is the description of what the definition is. The patient has placed this entry into their own record. Simple. Call it what it is. Not a patient. Not
But
a problem.
eventually, all that stuff will fall off because we went into the system with a full-fledged record that only the inputting is at the doctor's locality.
Okay, great. So as I said, I'm a patient visiting to a doctor having an Epic EHR, and he has given me access to the patient portal of Epic. And after a few duration, I visited a B clinic, and he is using iPatient EHR, and he has given me access to his patient portal. So those will be a collective information on UMR portal, right? If I want to choose the UMR portal to be centralized documentation of my medical record.
The answer is yes. I was hoping that Wayne would ask that, yes, but the answer is yes, correct.
Yeah.
And a matter of fact, what we would do, and that's a very intuitive question, is that we would look at the top 5 hospital EMR systems and create an API that would allow us to put all that data into this system and amalgamate everything. And it would even show where it came from as well. Because one of the things that once we integrate this stuff, the patient now can trend all their data on one place.
Right.
Which you can do right now, anywhere.
It's almost same like we had 20, 30 years back, having a different files of different physicians. And now we have a different digital records of the different physicians.
Well, not only physicians, a record from every institution that you've been to.
Every institutions have. So it doesn't make much changes, but with the help of the UMR portal, that is a revolutionary that brings us to a point of information during the emergency or during the right treatment, as you correctly
Well,
went through
it's during any healthcare encounter. You would want to have your dentist look at this. You want to have the school nurse at this thing. We want to be able to have this thing as part of your employment record.
employment. Yeah.
So this is your lifelong record to be able to ascertain your complete managed healthcare, so nobody can do any harm to you.
Right.
Remember, this will be tied into the pharmacy. It's going to be tied into the laboratory. It's going to be tied into
That's
your
very
radiology
important.
facilities.
Right. All the healthcare facilities, any digital interaction of your medical record would be put into the UMR and access to those appropriate providers that are registered.
And one of my known persons said the next pandemic would be an antibiotic.
I'm sorry, can you repeat that question, the statement?
Yeah, one of my known persons said the next pandemic might be an antibiotic.
Right. This will, as Wayne will probably state, this will track in real time a pandemic and epidemic. It can give us information on localities and what's hot and what's not. So
Right.
you can do community demographics. Wayne, why don't you go into that?
Yeah, because what you're doing, the pandemics are all defined by, geographic location and time and the changes of those two interactions. And this record would start picking that up very quickly in real time. Number one, in real time, because when you close your EMR, it can export to UMR. So it's up to date and it's collating all this data and through the background algorithm could come up with, pandemics, endemics. The other thing that the record will be able to do is predictive modeling, which is so critical for a country to plan their healthcare and to see the particular diseases as they are increasing over time across the country, not only locally and in each region, but also across the whole country, to see what the healthcare needs are going to be locally and where to plan certain types of healthcare to take care of particular
That's
problems.
exactly what the Indian government is doing. They have built up the unique patient ID and circulating among the healthcare industry to start uploading the data, whatever you have.
That's right. And this is where predictive modeling will be done through this record by capturing all the different digital healthcare interactions of each patient in a real-time basis so that the government can see where to put what type of resources to take care of what type of different problems throughout the different parts of the country because their healthcare needs are different. And just as the politics is different and the economies are different, so are the healthcare needs. And certain people have certain types of infectious diseases compared to others and certain types of medical problems compared to others based on diet, etc. So this record would be able to show all the real-time and predictive modeling of those areas. When you have all the data in one place, you can query it any way you want to get the information you want out of it.
You're not going to get skewed data. And also one other thing that you mentioned about the government, okay? The government's going to really need this system because even though they have all this data, right? It's manageable data, as Dr. Wayne said, that the fact that in 3 minutes or less, you can get this complete record understood. So it becomes more valuable to the hospitals and doctors when you're seeing these patients for coordination of care. And a matter of fact, this data back in the States will be so valuable when you come into the hospital because the hospitals can actually generate more income based on a complete review of the patient's record.
Can someone mute their microphone and just unmute whenever you want to speak, whoever. That way we can keep down the background noise. Thank you.
Wayne, did you want to go back on a little bit what I just said about having this information to the hospital, where the hospitals and doctors could actually bill for a higher rate?
Well, yeah, if you're getting paid based on your coding and the ability of you to code all the different diagnoses, and the government needs to know what the complexity of the diagnosis are, again, so that they know what's going on in their population, then this gives you all the different codes from the different medical problems. And the more important, quote, super codes, unquote, are going to be related to your cardiovascular medicine, your pulmonology, and your nephrology. So these different medical problems interact along with endocrinology for diabetes, for example, so that these different codes interact to give you a higher level of coding, which gives better reimbursement if you're being reimbursed by the complexity of the diseases that you're taking care of in a patient. Otherwise, you're literally undercoding what you're dealing with because you're not accurately describing it based on having all the codes and putting them together to give what's called the super code. Or now they call it the summation code, if you will, that gives you more digits and more specificity, and having the accurate documented accurate specificity here in the record to do the best coding possible. And then the company, the insurance, or the government gets that accurate specificity coding. So it helps in reimbursement. Also, it helps in reimbursement if you are, if you're going to be capitated, then you're already paid for your care. And any testing you do comes out of your pocket. So if you have that testing that's been done recently and is recent enough that doesn't need to be repeated, then you already have the data that you want to get based on evaluation of that patient. For example, an echo test that's already been done, or a heart cath. You're not going to, like I showed in this one example, you don't want to do a specific high-tech test that might be done once in a lifetime and do it 3 times in a period of 3 or 4 weeks, when it's really a matter of knowing the test was done and being able to go to the right spot and get the results and have it right there when you need it before you start ordering tests, because you've already seen it done. So that's where this record really helps to reduce and stop any redundancy, and to use the information that's already in the record and get those results to make forward-thinking assessments and diagnosis and treatment plans.
Yeah, very well.
Any other questions?
Yeah. Yes, Dr. Wells. So I don't know if this would be technical again. Sorry about that. But you know, just in case of emergency, you know, a practice, a setting, or a provider has to identify the patient. Are we planning to integrate a retina scan or a fingerprint just in case the patient is not conscious? You know, how would they be able to identify the patient?
Right. Excellent question. And I think that is a razor question, an IT question. But I think what I would say is any of the biometrics that are out there being used, whether it's retina, whether it's fingerprint, facial recognition, you know, whatever system is being used, it's really just a matter of a front end of this record identifying the appropriate requirements to identify the patient to be able to get access to the record.
I'd like to add one thing, which I don't know if Mukund was, if we should ever explain something here, but we're also looking to go into wholesaling of P450, which would be basically the DNA of your metabolism of drugs based on your DNA profile. So once that is brought, this will not only prevent drug disease and all that other allergies and interactions, it's going to reduce adverse drug reactions, but more importantly, we'll have their DNA basically on profile here. So if you have the DNA, which I'm sure you can basically rapidly identify DNA, this would also identify the patient as well. Because because some of the things that you brought up, a retinal scan, well, the fact is the guy is comatose, whatever. I don't think your retina would be able to be exposed to actually identify a person if, let's say, you're brain dead. I don't think, I mean, I've never experienced this. Well, maybe you could answer that question.
Well, if they're brain dead, I think it's a moot point, but you're still going to give care because of the requirements. But I'm not sure about the retina and the circulation, et cetera, and retina scans, but the pharmacogenome that Stephen was talking about would go into the drug laboratory interactions, and it would give you the list of the, for example, antidepressants that would best work with the patient based on their CYP450 profile. And again, to reduce the amount of drug interactions or drugs that are not effective and have more side effects, because you're increasing dose trying to get a benefit, and you're just causing more side effects because the drug's not going to work. So that's a drug laboratory interaction. And that's just an example. As technology expands, this record, because it has all the codes and they're all integrated with each other, it's going to be handling any kind of new type of data that you need to get. Because as Stephen says, the DNA, the real DNA is in this record. It's in the system, and the DNA is in the codes and the capture of those codes and putting it in here and integrating it into the different disciplines that are interrelated as opposed to segregated. So it's everyone's working together trying to do what's best in the patient's and the country's interest.
I have a question here. This is actually for Mukund. Mukund, you're asking about the biometric. Now,
Yes.
when do you suppose the biometrics is going to be used? Because right now the system, the app, for example, use the biometric to obviously let them access their records. why else do you see or imagine biometrics is going to be used as part of universal medical record?
That's a razor question, and it's to me just a front end access. Whether you type in your password, your fingerprint, your eye scan, your facial recognition, you have a key that you plug into a USB. You have a key thing that you plug in, or some other way to recognize you, to identify you, pre-recorded.
No, wait. I was actually asking Mukund to get his perspective. Where does he see the biometric?
Point of entry of the patient.
Yeah, see, front end, yeah.
Okay, if that is the case, we already support that. Whatever biometric is supported by a device, we support that as of right now.
Wonderful, wonderful. But as Dr. Kohn said, I mean, once we have the DNA, I mean, that would be wonderful. I mean, that would be way beyond biometric. But yes, I'm glad to know that we are already on the biometric thing. Thank you.
Any other questions, or any thing that you didn't understand or would like explained in more detail to help you understand the basic overall system?
No, doctor. This was pretty easy. You've explained it well, and I'm very excited. I want to actually see this working with a lot of patients with us.
Thank you.
So would we. We want to see a lot of doctors on this because, as Wayne showed what the UMI is all about, it will shave time and everything else, even for ambulance picks up. I mean, so the fact is, there's a lot of things that I want to be able to see. I want to be able to see 10,000 doctors on this within the next year and a half, so we can get into other services that I just want to touch on. It's not pie in the sky, but I've discussed this with Rushil, and I just want everybody to hear this, that, with your smartwatches that are made by Apple in India right now, we built a product years ago, but I'm looking at it that when you have your mobile device, your watch, saying that you have high blood pressure or whatever it may be, we want to be able to route this information immediately to the nearest ambulance to pick you up through our call center that would then be able to treat you and track you immediately to have this information before they pick you up. So it's a concierge services that'll generate more enthusiasm for high-risk patients.
Yeah, Stephen makes the point that, if, for example, if someone calls from home and they have an emergency and they're calling an ambulance, they could give them the name, and they could access this record based on the information they're given, of course, because of HIPAA. And they could pull up the record, and they can know what their medical problems are, their diagnoses. They can know their medications. They know their allergies before they pick them up in the ambulance. And they can also notify the emergency room they're going to go to, which obviously going to be different depending on where they are, and they know where they're going. And the emergency room could also have access to this record, knowing what type of medical problems they have, their medications, their allergies, and all this is known before. So when they come in, even if they're comatose, once they've actually been identified, they will have access to the record and can start treating them, and more importantly, not harming them by giving them a medicine they're allergic to, or double dosing a medication they're already on, etc.
But in addition, this could also notify your next of kin what's going on and where you're going as well.
We talked about that with the emergency information, being able to automatically blast as many, with extended families, they may want to have 50 people notified. And, you just really technically need to get out of the 50. If you can notify one, the 50 will be getting it amongst each other. But the point of this is that you're not going to have an individual who should be involved in the emergency evaluation and treatment and transport of a patient in the emergency situation, spending their time instead contacting the family, and the family upset because so-and-so wasn't contacted. The blast is sent out. It's up to them to have the mechanism to be able to receive it, as has been predetermined in the record for their request. So that's, there's a lot. And I think the important thing to tell you is that the more you get into the record, and we've learned over the years, and as things have changed in medicine, the record still stands on its DNA, and it still has the backbone and the interconnections to provide what new things have been requested of it, because it's comprehensive. It's got everything in it.
Exactly.
One other thing too that I'm going to share with you, and I discussed this with Rushil, is the fact that when you talked about identification, well, doctors and hospitals get reimbursed for medical data they sell to Big Pharma. I'm looking at this as a way for patients to get reimbursed for their data now. That's not only in one place, but you can target now manufacturers of pharmaceuticals for better information, and maybe give the patient back 50 cents or $1 for their data that you can put on a medical savings card, that now that card will be with you forever. And therefore the banks make more money, and this will generate them to using a bank card, that now when you go get medical services, it'll show that the patient is compliant as well, which could be additional incentives for insurance companies to show, hey, patients are doing what they're doing. They're now compliant.
Yeah, we see this as a way to show adherence rates of patients and to reward them for their good behaviors, and financially or whatever, giving them monetary points, if you will, that reduces their copays and their cost by being adherent and doing what they're supposed to do in the patient-provider relationship. And it's their half of the bargain, and they're rewarded for good behavior, which they should be.
Wayne, so providers are what? Compliant or adherent?
Providers are compliant, patients are adherent.
Right. Okay. So now we'll show that the patients are adherent, as well as the record will show that the providers are being compliant with prior treatments, which they can't really do right now. Correct?
Right. And you can also show, of course, you've got, guidelines and other things that could be put into the record, and they change, of course, but all that could be put into the record to help give a consistency in provider care across the country based on certain diagnosis. And actually, there's another form that I've designed to be able to show each provider and who's responsible for each code. So that if for example, a primary care was taking care of a patient with heart failure and that worsened, they could just take and pull that code down into the cardiology entry, and that would notify the cardiologist and get them an appointment with the cardiologist. And the cardiologist now would be responsible for taking care of that particular code of congestive heart failure. And the cardiologist now, when they get into the record, they can see all the tests that have been done previously, and the latest tests and all the tests. They can see the results of the last x-rays and the results of echoes and EKGs and all the different types of studies that the primary care and maybe the pulmonologist and neurologist have done. It doesn't matter who they are. It's going to be integrated into this record based on disciplines, and the cardiologist can see all the different testing and results that have been done on this patient. So they can then decide what types of things they need to do and the medications they're on and their allergies, and they can treat the patient. And once the patient is stabilized and doesn't need the higher level of cardiology care, the cardiologist can take that code and drag it up into the primary care's responsibility, and the primary care will be notified when that happens through the record. And now the primary care is now taking care of that particular code on the patient again. And it helps to reduce the cost of care because you're not using specialists for things that primary care can take care of, and vice versa. Primary cares aren't trying to manage things that really need to be referred. And the data is seamlessly transferred just by moving that particular code from one provider to another. And it notifies them, and the record is there for them to access and to look at all the data. That's another example of using this record so everyone knows what they're responsible for. That's really critical for cancer patients, for example.
Great. I just wonder, how do this population health management folks works with the data that they have?
I don't know that it works. I don't know that. I mean, everyone seems to, the primary care especially, seems to be responsible for quote unquote everything because it's on their plate. And only with their relationships with specialists do they take it off their plate and give it to the specialist. But that passing back and forth is not a smooth transition of information. And having this record would allow that because it's all in the same spot. And, patients move around. They move around to different parts of the country. They move around with different providers. They may get second opinions, for example, or see 2 or 3 primary cares about something. They may go to a specialist when they really are going to the wrong type of specialist, for example, if they self-refer, which they do. It depends on the medical system that they're in. So this helps to avoid a lot of these types of things. And it helps, more importantly, any provider to very quickly look at the record with the information they want and need to know, get in and get it and get out, and then take care of the patient that's sitting there in front of them as the clock is ticking with their very, very limited time that they have for this patient.
Yes.
That's the beauty. For example, to give you a very specific example, let's say that in this example, we're looking at the record right here that I have up, and the patient was seen last time 3 months ago. So rather than the provider asking, what have you done since I last saw you in the past 3 months? And oh my God, they have been everywhere and done everything. Rather than asking the question, all they need to do is take the color filter and change from the red to the orange color, yellow color, and put 3 months in that. And then everything in the past 3 months is going to show up red. And all they have to do is go to this red color and highlight it, and it will show them everything that has been done in the past, well, I'm logged out, in the past 3 months. It'll show them every code that has been generated since the last time. And so their answers, they're right there in front of them. They don't have to ask the question. They can look in and say, oh, I saw that you saw this provider and they generated these codes, and these are the tests that were done. These are the results of the test. These are your new medications in the past 3 months. These are the new lab tests and results. These are the new test lab tests and x-rays, whatever. So all that can be generated very quickly instead of asking the question and relying on the patient's memory, which is not going to be good, the names of the providers and the test and the medicines and the results and all that. It's going to be a nightmare.
You know, one of the nice things that this thing does, and I think Dr. Wayne explained it, is that this becomes a concierge service for the patient. So their records are exposed no matter where they go. So you've integrated all these different silos into a universal format that anybody in any time could understand this record in a few minutes or less. I mean, and that should really be the core focus of what this really is. It's a patient-centric record, integrating everybody. So you're breaking down the walls to all these different silos.
Yeah, and any provision to identify early stage of cancer?
You bring a very interesting question, and it's going to go back to the P450, okay? If we get your DNA, and let's assume, because there's other things that we wanted to go into, because like, for example, we wanted to get your genetic profile and be scanned, but this is going to be a phase 2 or phase 3. We want to be able to wholesale lab tests. So for example, here in the States, let's say there's 4 million babies born every year, 2 million are women, 2 million are males, right? We want to be able to do BRCA screening on a wholesale basis, which I would like to bring this back concept into India. So let's assume we can do wholesale screening for people, and let's assume they have a DNA profile of certain types of cancers, okay? We're looking to have early intervention because maybe some kind of protein alteration would affect the outcomes to prevent. So first of all, the disease management outcomes of the records we have, we can actually see how diseases get manifested. Maybe early intervention of having a DNA analysis by taking certain types of proteins or certain types of scientific breakthroughs will actually prevent certain proteins from being masked. And if we go back, and if you know you have a DNA profile for certain types of cancer, maybe the fact that early detection of proteins would actually then have a different alternative pathway where we can give you some kind of protein alternative pharmaceuticals or whatever it may be to prevent anything from occurring and masking these proteins from being added into your body regime. Wayne?
Yeah, the other thing is that there are now blood tests that detect several hundred types of cancers, and there are solid cancers and liquid cancers in the body, and these are new emerging technologies of blood test. This is something, obviously, if a person does that, they want to share it with all their providers. They want all their providers to see the results of their test because each provider may actually have a different perspective of that information. And the same thing if you're doing colonoscopies or Cologuard tests every 3 years, you want that information shared, and someone needs to keep up and keep the patient adherent to what are the recommendations of repeating these particular tests. This is also important, for example, following a patient with heart failure. You want to make sure that they're getting an echo every year or every 3 years, whatever the cardiologist wants. And in this record, you can set up tickers that will notify the patient and the providers that it's now time to repeat certain tests. So there's all kinds of things when you have all the information in one place that it allows you in the background and with Ray's expertise to put this type of ability in the record to help not only improve adherence, but to reduce repetitive cost of things not necessary to repeat.
Yeah, the best persons would be the insurance people, because nowadays in India, insurance companies are letting individual know we also have a plan for cancers. So you can just pay a minimum amount and you'll be covered for the cancer for 1 year or 2 year. So
Right.
Those people should have a insurance plan as well as the test for those kind of patient in advance so that they can save money.
Right, and then any expensive test like that, you want to make sure that that information is shared with all providers, regardless of what part of the country they go to. It's in their record. They need to have immediate access. They don't need to, send a fax and request it, and someone decides when they get around to, making a copy of the results and then sending it to you. Medicine moves too fast, and it's too expensive in time and cost to be able to use these types of mechanisms for communication.
I agree.
Mukund, any other questions or anything we could answer?
No, doctor.
Thank you. Rochelle, any questions?
No, doctor.
Does this change your thought process on how we're going to attack the market? Because I wanted Wayne to know that I believe we really want to start focusing on OBGYN patients and pediatric patients, which this way they're grown into the system, and it starts adding more value, more marketing, more exposure, more social media about this as well.
Exactly. So we want the patient and the physician should have some kind of platform wherein they can document the detailing of their treatments.
Exactly. This is a physician and a patient record. It's the patient owns the record. The providers have themselves and all the different ancillary healthcare facilities putting in the documentation of it.
Yes,
we
doctor.
we want it comprehensive. We want every digital interaction captured in the universal medical record, which is shareable to all appropriate providers who need instantaneous access 24/7 anywhere in this record.
That's correct. So, right, we should also educate a patient so that if physician missed to maintain or document anything, at least patient will start documenting from themselves.
And this gives you all the portability that you need. Anything else, anybody? Because I know it's getting late for you, and
Yeah.
so appreciate your time and staying up, drinking chai.
Now we are used to it.
If not, we'll close the meeting, and I appreciate everyone's participation.
I thank
Yes, doctor.
everybody for the time, the understanding, and the compassion to make this thing a reality for everybody.
And we're here to answer any questions that come up, so just let us know.
Sure, doctor.
Well, thank you all.
Thank you.
Goodbye.
Have a good night.
Thanks.
Thank you very much. Bye-bye.
Bye-bye.